Now we move on to the digestive tract anatomy. If we look at the digestive tract, we have layers of the gut wall, and if we look at them from the inside to the outside, we first have the mucosa, which is basically the epithelium, and under which we have the lamina propria and the muscularis mucosa. So the mucosa consists of the epithelium, lamina propria, and muscularis mucosa, under which we have the submucosa. Obviously, sub means below something, right? So submucosa includes submucosal nerve plexus, where we have the Meissner's nerve plexus. This submucosal nerve plexus secretes fluid, and the submucosa also, the plexus doesn't secrete fluid, the submucosa secretes fluid, and this submucosa also contains vessels. And then we have muscularis externa, which includes the myenteric nerve plexus, which is named our back plexus, and the muscularis externa is part of the motility of the GIT. After which, in the end, we have the serosa. And whenever the serosa is intraperitoneal, it's the serosa. Otherwise, if the organ is retroperitoneal, we have adventitia. Now, before we go into ulcers and erosions, let's look at a little bit of this epithelium. Okay, so first of all, we have the mucosa, right? Now, this mucosa is the innermost layer, and it's the first to be damaged in any disease, right? So remember that any erosions are limited to mucosa, but the ulcers go deeper into submucosa, right? Just remember these two things. So any erosions will be involving the mucosa, but if there is like an ulcer, it will go deeper into submucosa. So the mucosa itself has 3 layers. It includes the epithelium, the lamina propria, and the muscularis mucosa. So these 3 layers, the epithelium, the lamina propria, and the muscularis mucosa, all 3 make up this mucosa, right? Now, the epithelium type varies by region. If we're looking at the esophagus, we're going to look at stratified squamous epithelium. If we're looking at the stomach or intestine, we're going to look at a simple columnar epithelium. So epithelium has functions like absorption, secretion, protection, after which we have the lamina propria. The lamina propria has loose connective tissue, and it contains capillaries, lymphatics, and immune cells. Something important in the GIT is GALT. This is gastric associated lymphoid tissue. So remember this, because we have GALT lymphomas when we have an H. pylori infection in GIT. We have a very high probability of getting a GALT lymphoma later on. So they involve the immune cells of the lamina propria. Then we have the muscularis mucosa. Muscularis mucosa is basically thin, smooth muscle. Can you see that these are smooth muscle cells? These thin, smooth muscles cause local movement of mucosa, which helps to secrete fluids and help in absorption also. So any erosions or damage, or basically erosional damage, is limited to mucosa only. But when we talk about ulcers penetrate into submucosa or they go deeper. Now, the submucosa is there for support and a control layer. The submucosa has blood vessels and it has lymphatics, and the submucosal glands are present in esophagus and duodenum, and the submucosa also has the Meissner's nerve plexus. This submucosa has the Meissner's nerve plexus. The function of the Meissner's nerve plexus in the submucosa is to control secretion, regulate blood flow, and coordinate the muscularis mucosa activity. So the muscularis mucosa just above it, the activity of that layer is coordinated by the Meissner's plexus. So whenever you think about submucosa, you can think about secretion and supply. Then we have the muscularis externa. This is responsible for motility or peristalsis. It has 2 layers. It has an inner circular layer and it has an outer longitudinal layer. So can you see that the direction of these muscles is opposite? So this is the inner circular layer and this is the outer longitudinal layer. So between these 2 layers is a plexus called the Auerbach or myenteric plexus. The myenteric plexus is present between the 2 layers of the muscularis externa, the inner circular layer and the outer longitudinal layer. The Auerbach plexus is present in the middle of them. They control gut motility and coordinate peristalsis. You always think about movement when you think about muscularis externa. Now, if an organ is intraperitoneal like the jejunum, it's going to be covered by mesothelium like the stomach or jejunum. and the outermost covering is going to be the serosa. But if the organ is retroperitoneal, so it's behind the peritoneal cavity, like kidneys, pancreas, duodenum, I mean some part of the duodenum. Then if an organ is retroperitoneum, like the esophagus, duodenum mostly, it anchors the adventitia anchors the organ to surrounding tissues. So whenever we have an intraperitoneal organ, the outermost covering is the serosa, but whenever we have a retroperitoneal organ, the outermost covering is the adventitia. Now remember that the gut has its own intrinsic nervous system. So we talked about two nerve plexuses here. The first one was the Meissner's plexus, which was part of the submucosa. So the submucosa had the Meissner's plexus, and this Meissner's plexus controls the secretion and blood flow, right? And the muscularis externa, the two layers of the muscularis externa, between these two layers is the Auerbach plexus. The Auerbach plexus controls the motility, right? So the Auerbach plexus controls the motility, and the Meissner's plexus controls the secretion and blood flow. Now we also have some interstitial cells of Cajal. These are basically just like you have pacemaker heart cells in the SA node, you have pacemaker cells in the interstitial cells of Cajal. In the GIT, they basically generate slow waves. This is the basic electrical rhythm of the GIT. And they're mainly located near the Auerbach plexus, right? So when you have the Auerbach plexus between these two layers, this is where you have most of the interstitial cells of Cajal, and they basically generate the slow waves, which is the basic electrical rhythm of the GIT. And the frequency of slow waves is highest in the duodenum, then they're slower in the ileum, and then even slower in the stomach. So the slow waves determine the maximum contraction rate, not force. It only is related with the contraction. It has nothing to do with force. Force is depending on neural and hormonal input. So these slow waves are basically the highest in the duodenum, and then the lowest in the ileum, and even lowest in the stomach. So something important here would be like a peptic ulcer. The peptic ulcer is going to extend into the submucosa, which is why there's a bleeding risk, because the submucosa has vessels here. And then we have achalasia or Hirschsprung disease. In the Hirschsprung disease, we have the enteric nervous system defect. The Hirschsprung disease is when there's an absence of Auerbach and the Meissner's plexus. Sometimes it's both, sometimes it's just one. And achalasia is basically when there's a loss of myenteric plexus in the esophagus. Whenever there's a loss of myenteric plexus in the esophagus, you get achalasia. And bleeding ulcers, a submucosal vessel involvement is going to lead to a bleeding ulcer. Now there's something called as inflammatory bowel disease. The inflammatory bowel disease involves the mucosa and submucosa both. Okay? An inflammatory bowel disease will involve the mucosa and submucosa. And diabetic gastroparesis will impair the overall motility. So basically, it's a dysfunction of the interstitial cells of Cajal. That is something you must know. Now, when we can you look at the smooth muscles here? So there's a circular smooth muscle and the longitudinal smooth muscle, and in between you have the Auerbach plexus, right? And we said that if the organ is intraperitoneal, it's going to have a serosa covering it, right? This is covered by mesothelium. But if it's retroperitoneal, an adventitia is going to anchor the organ to surrounding tissues. So by looking at this serosa, we know that this organ is intraperitoneal, probably jejunum or stomach, we don't know. Now we look at the esophagus epithelium. Before moving on to the epitheliums, let's just revise this. So ulcers can extend into submucosa, inner or outer muscular layer. Erosions are in mucosa only. Frequency of basal electric rhythm. The slow waves originate in the interstitial cells of Cajal. They were mainly located in the Auerbach plexus, and they're fastest in the duodenum, or they're highest in the duodenum, and then the ileum, and then lowest in the stomach. Okay, moving on to digestive tract histology. Let's look at the esophagus first. So this is a picture of the esophagus. This is the this is basically a longitudinal section of the esophagus. It's a picture from the Jenquera, and I don't know if you know about that book, but this is a picture from the Jenquera Atlas, and this is the stratified squamous epithelium of the esophagus. This is the lamina propria. This is the muscularis mucosae. These are your glands, and these are the ducts that are opening into the muscularis mucosae. Then we have the striated muscle cells here, the smooth muscle fibers here. That's something. Okay, so that's your esophagus. Something else that I would want to show you is this is the epithelium. These are the connective tissue papillae, the muscularis mucosae. Above it is the lamina propria, submucosa, muscularis externa. This is that same image. So the muscularis externa for the esophagus is very important because the upper 1/3 of the esophagus is skeletal muscle, the middle 1/3 is mixed, and then the lower 1/3 is smooth muscle, because the lower 1/3 is completely involuntary, but the upper 1/3 is voluntary, so it's skeletal muscle, right? That's something you should know. Moving on from the esophagus, something about the esophagus. What kind of an epithelium does the esophagus have? It has a non-keratinized stratified squamous epithelium because it needs protection against the abrasion of the food bolus. So that's why it's non-keratinized stratified squamous. The lamina propria of the esophagus is made of loose connective tissue, and some mucus glands are present. They're more in the upper part. This is the duct that is of the gland. And then the muscularis externa I've explained. The upper 1/3 is skeletal, the middle 1/3 is mixed, and the lower 1/3 is smooth muscle. Remember that whenever you have an exam clue where there's a stratified squamous epithelium and no villi, and the muscle type is changing, this is an esophagus, right? Moving on to the stomach. Whenever you see a stomach, we see the epithelium of the stomach is simple columnar. So this is a simple columnar mucus secreting epithelium of the stomach. It has no stratification, right? The surface has these gastric pits. You can see the pits here, and that's why the gastric glands are also present there. The gastric pits basically lead on to the gastric glands. You have parietal cells here. You have chief cells. The parietal cells basically are large, eosinophilic, basically pink cells that secrete hydrogen chloride and the intrinsic factor. The chief cells are basophilic, they're more blue. The chief cells are basophilic, they're more blue, and they secrete the pepsinogen. And then we have the enteroendocrine cells, they're hard to see here. And then we have the muscularis externa. Let me show you the muscularis externa. Okay, I can't really show you the muscularis externa here. But we have 3 layers of the muscularis externa. So whenever you see pink parietal cells, these pink parietal cells and blue chief cells with no villi, you know that this is a stomach. Remember, chief cells, parietal cells are large and pink. The chief cells are basophilic blue. Let me show it to you on another image. Wait. Okay, so you can see the chief cells here. They're basophilic, they're blue, and they secrete pepsinogen. And the parietal cells are large, eosinophilic, and they're pink. They secrete hydrogen chloride and intrinsic factor. So whenever they ask you what kind of cells produce the hydrogen chloride, the acid, and the intrinsic factor in the stomach, they're the parietal cells. And the pepsinogen secreting cells are blue, they're big, they're basophilic, and they're called the chief cells. We now move on to the duodenum. Now the duodenum, this is the difference between the duodenum and the pylorus. That's the stomach pylorus ending onto the duodenum. So you can see the pyloric glands here that sort of end here. So there are no more pyloric glands here because this is the duodenum. In the duodenum, the key histologic features include the simple columnar villi plus the microvilli. You can see the villi and microvilli here. And then we have something called the Brunner's gland. The Brunner's gland are present in the submucosa, and they secrete an alkaline mucus, basically the hydrogen carbonate, which neutralizes gastric acid. Okay, so the Brunner's gland secrete alkaline mucus, which neutralize gastric acid. And we also have crypts of Lieberkühn, which contain stem cells. You can't see them here. Okay, you can't see them here. We have crypts of Lieberkühn here, which contain stem cells, and also Paneth cells. Let me show that to you. Wait. Okay, so these are the crypts of Lieberkühn, with basal oriented Paneth cells. The Paneth cells basically secrete defensins, lysozyme, and tumor necrotic factor. And these are basically the crypts of lubricant, right? And between the Paneth cells, undifferentiated progenitive stem cells are found. These the progenitor cells are basically stem cells, and that is something you should know for the crypts of lubricant. They're present in the duodenum. So whenever you see villi and Brunner glands, go for duodenum. There's no debate here. Whenever you see villi and Brunner's gland, your answer is duodenum. Okay. We now move on to the jejunum. The jejunum has plicae circularis. These plicae circularis, these walls of Kirkring, are tall, thick, and numerous because they increase the surface area maximally. There are no Brunner's gland in the jejunum. They're long, they're finger like. The villi basically are long and finger like. They have like a feathered appearance, and you can see that here. They have like a feathered appearance. So, whenever you have tall villi, prominent folds, and clean submucosa, go for jejunum. We now move on to the ileum. The ileum has shorter and blunter villi. So these villi are shorter and blunter than the ones in the jejunum. They have aggregated lymphoid nodules, not seen here, which are basically Peyer's patches. So the Peyer's patches are aggregated lymphoid nodules which extend from the lamina propria all the way to the submucosa. So this is where you have the aggregated lymphoid nodules. So this is basically a Peyer's patch. Can you see it? It's part of the submucosa and it's an aggregated lymphoid nodule. This circle shows you a Peyer's patch circled. And so the villi are, going back to original image, the villi are shorter, blunted. You have Peyer's patches here and they extend from the lamina propria all the way to the submucosa. Also, the goblet cells are more in the basically ileum compared to the jejunum. Remember that. So whenever you have villi, lymphoid aggregates, it's the ileum. Okay, and shorter and blunter villi, by the way. Then we move on to the colon. The colon has no villi, zero villi. It has crypts of lubricant only, which are basically strong and tightly packed. You also have goblet cells here. Yes, goblet cells are very abundant. They're helpful for the lubrication of feces. Also, you have the muscularis externa here, and the muscularis externa here has something called the tinea coli, and it's a gross feature. You can't see it on the microscopic picture because the tinea coli are like lines because they increase the surface area of the colon, and that is something you can appreciate on gross. So when there are no villi and tons of goblet cells, the answer is colon. Okay, that's your digestive tract histology. Let's just revise it. So esophagus was non-keratinized, stratophagus commus. The upper one third was skeletal muscle or the striatal muscle. The middle and lower was smooth muscle with some overlap in the middle one. The stomach had gastric glands, parietal cells, and eosinophilic. The parietal cells are eosinophilic, they were pink, and the chief cells were basophilic, right? Isn't that what we just covered? Also, something about the stomach. What were the parietal cells doing? The parietal cells were, does anyone remember? Large eosinophilic pink ones, and they were secreting acid and intrinsic factor. The chief cells were, on the other hand, blue, and they were secreting pepsinogen. Duodenum had villi and microvilli to increase the absorptive surface. They had Brunner's gland that were bicarbonate secreting cells. You can remember it by BB. They had crypts of lubricant containing stem cells, also Paneth cells that secrete defensive lysozyme necrotic factor, and plicae circularis, right, in the distal duodenum. Then the jejunum has villi, again crypts of lubricant and plicae circularis, taller, more prominent, numerous versus ileum. Their villi had a feathered appearance with oral contrast and increased surface area. Then we have the ileum, which has Peyer's patches and lymphoid aggregates. What were Peyer's patches? They were basically lymphoid aggregates in lamina propria, submucosa, plicae circularis in the proximal ileum, crypts of lubricant. Largest number of goblet cells were in the small intestine. The colon had crypts of lubricant with abundant goblet cells, but no villi. That's like this. You should just learn this by heart. This is a very commonly asked exam topic, the digestive tract histology. I hope you remember the Meissner's plexus and the Auerbach plexus. So I'll just stop here before the next video.